Hi, this is Clyde Yancy here at American Heart Association Scientific Sessions 2022. Today we had the most incredible moment thinking about the first session of late-breaking clinical trials, a session subtitled Changing Clinical Practice. Boy, did we set the bar high, right?
We did. It was a wonderful session. When I read through the program, I really thought, these are questions I want to know the answer to. These are everyday questions that really clinical cardiologists have to grapple with.
Exactly. And for those of you that don't recognize Dr. Pradhan, she is from the Brigham and Women's Hospital and was a PI for this incredible trial known as Prominent. Now, let's kind of start from the perspective of the everyday physician who's taking care of patients either for primary prevention purposes or secondary prevention purposes. This is what we should know how to do. So the patient shows up and has dyslipidemia in the global context, but in addition to having an elevated cholesterol, elevated non-HDL, we discover the triglycerides are elevated. So first, help us understand, what is that risk of hypertriglyceridemia?
Yeah, we've had abundant data, decades of data, telling us that patients with high triglyceride levels, whether they're fasting or non-fasting, have an extremely high risk of cardiovascular events. And we did go down this path of trying to disentangle low HDL from high triglycerides, which was the confounder and which was the actual mediator of risk. After a number of trials that failed to show that raising HDL lowered risk, we settled on treating hypertriglyceridemia. And so this decade really has ushered in 3 trials that have looked in patient populations selected on the basis of high triglycerides, what do different treatment options offer in terms of cardiovascular risk reduction. And Prominent took the approach of using the insights from prior fibrate trials that showed us that if you offer type 2 diabetic patients with hypertriglyceridemia, low HDL, a PPAR alpha agonist, you can reduce triglycerides potentially, and in post-hoc analyses, you can also lower their cardiovascular risk. So we set out to really provide proof in the pudding for that hypothesis.
And just to keep the conversation global, we know that there is a concurrent theme that we're continuing to navigate, where in the patient, for secondary prevention particularly, who has elevated triglycerides, using icosapent ethyl may have some benefit there. We continue to wrestle with how to interpret some of those data, but then along come the fibric acid derivatives. And we know, interesting enough, that there were predicate data to suggest that this might actually work.
Right.
So when you design Prominent, how did you think about this space that's got so many different options in it now?
Yeah, I think for us, we felt that we needed to address residual risk in patients with type 2 diabetes. You know, in clinical, as you know, in clinical trials design, you seek a high-risk population, and certainly a population which you have added therapy to offer beyond standard of care. So we chose patients with type 2 diabetes and a common dyslipidemia pattern. In the US, up to a third of patients with type 2 diabetes have this profile. So it's a common clinical problem, high-risk patient population, and the prior data, as we talked about.
And I enjoy that you incorporated those with both primary prevention and secondary prevention indications, really trying to answer that question. What are you to do when you see the patient with hypertriglyceridemia? So let's move on to what you discovered.
Yeah.
The trial results I thought were fascinating.
Yes, so we found that despite doing everything we had hoped for, a 25% reduction in triglycerides, 25% reduction in ApoC3 and VLDL cholesterol, the things that we believe are pathogenic, atherogenic, and the things that the genetics tell us we should be caring about, decreasing ApoC3, we did not get a risk reduction in terms of cardiovascular events. Along the way, we found that the drug also increased LDL cholesterol. And many may say, well, that's something we didn't want to see, but to tell you the truth, that is telling me that the drug is doing what it was supposed to do.
Really?
It's converting triglyceride-rich lipoproteins into their catabolic derivatives, which are the LDL particles. So it's telling me and perhaps in contrast to prior studies, if you look at the prior fibrate trials, you didn't get this change, that we are actually on the right track in terms of hitting the right pathway. We just need to now clear those particles, hit this pathway, clear those particles. I think that's where we need to go next.
So that's part of what I identify as being fascinating. Exactly what we expected to happen occurred. We saw the drop in triglycerides. We saw the drop in VLDL, even ApoC3, but then the end result showed that the addition of a fibric acid derivative did not change these very important clinical outcomes. Now what?
Yeah, absolutely. These findings are puzzling, but they also are clinically and biologically relevant. I think we are getting closer to the real biology here with this trial. We need to understand, so total cholesterol didn't change. ApoB had a 5% increase, the things that we don't want to happen. But the intermediate steps that we saw suggest that if we can clear these particles after their conversion, that we may actually be onto something here. And I'm hoping that the ANGPTL3 inhibitors, the ApoC3 inhibitors, which have a much greater triglyceride reduction and have some LDL reduction in the case of the ANGPTL3 inhibitors, may get us the rest of the way.
Well, Dr. Pradhan, I'm glad you touched on that, because I think what was lost underneath the headline that there was no benefit on these hard outcomes was this optimism that the trial sufficiently informed us we have a new direction of research.
Yeah.
Because we can't walk away from this evident risk that is associated with hypertriglyceridemia that may not be fully attenuated with standard therapy, but we need to continue. And I thought you did a brilliant job of saying, let's use what we've learned to take the next step.
Yeah.
So here's the thing that I think is an important takeaway. Once again, statin therapy is still sitting in the throne. It still reigns supreme.
Right. Absolutely. I mean, I think I can say unequivocally that on the background of high-intensity statins, that there was no additional benefit. And that's really going to be the clinical question. You got your patient on a high-intensity statin. Is there any value then to having them on a fibrate as well? I would have to say our data did not support that strategy.
No, I agree. And as I tried to sum up this morning's trial, one of the things I wanted to say was for the patient I see, for the purposes of prevention, if there is concomitant hypertriglyceridemia, I'm going to be a little bit reticent to go ahead and start a fibric acid derivative. One last conversation we always need to introduce in these sorts of dialogues. It wasn't without harm, or maybe without risk.
Yes.
Let's talk about that.
Yes. So we did notice throughout the course of the trial, and I'll be presenting these data later in the in-depth session, that levels of creatinine, levels of EGFR did actually go up with pemafibrate, but they reverted to normal after cessation of the drug. Although we've known this about fenofibrate for almost a decade, it's not really clear what that mechanism is. So the biomarker changes are there. We had some physician reports of actual clinical events, but if you look at the entire population, yes, there was some change in renal function, but with cessation of the drug, normalized.
There was a signal on thrombosis as well.
Yes.
So why don't you give us a single sentence
that
we can take home and say, this is the summary of Prominent as we go forward?
I would say that the Prominent trial showed us that the importance of looking at subgroups that we've sort of been wishfully thinking may actually guide clinical practice, and that we need randomized clinical trials to definitively support that kind of strategy, that wishful thinking based on subgroup analyses from prior trials. I think that the book is not closed for those people who believe that now this is another nail in the coffin for triglycerides. I don't think that's the case. I think it's actually a step in a right direction to getting to the right type of therapeutic option we want for these patients.
And so I'll add to that three things.
Yes.
The first is that Prominent demonstrated that despite our enthusiasm about the pragmatic trials, we still need rigorously designed, randomized controlled trials to answer these very important questions.
Yeah.
It has to be the combination of both data
Yeah.
sources. We can't retreat from what has served us so well to go into a new area, exciting and appropriate in many ways, but there's still value in the RCT. The second thing Prominent tells us is that as we're trying to manage this hypertriglyceridemia issue, let's be patient. Let's wait for the next iteration of the data. Let's not assume that the fibric acid derivative is what we should use regardless. But the third thing it tells us, and I'll come back to what I said before, statin therapy.
Yeah.
Statin therapy. We
Right.
cannot overlook statin therapy, particularly high intensity statin therapy in those as indicated by the guidelines.
Absolutely, would
It's
agree.
been a pleasure to talk to you about the Prominent trial.
Me
Thank
too.
you for bringing these data to the AHA Scientific Sessions 22. We greatly appreciate your
Thank you
contribution.
so much.
Thank you so much.
Thank you.